Hello, my name is Tim Osborn. I'm a anesthesiologist here at Innovate Surgical. I have been here since the facility opened. I have worked on developing our pain and nausea protocol that we have used and modified here and there in the roughly 3 years that we have been open. For our nausea control part of taking care of our patients, in the pre-op area, everyone gets Zofran, 8 milligrams ODT, Pepcid, 20 milligrams IV, a scopolamine patch. We do not usually discriminate on age for the scopolamine patch. I put it on everybody pretty much even up to 80, 85, unless they have a history or of any kind of a bad reaction to anything that might make me not want to do it. But 90+% of the people get this scopolamine patch. I know that a lot of people do not put them on over the age of 70. We still do here. We may take them off the day of surgery if they're acting a little confused. We reserve Phenergan 6.25 IM for anyone who's got a very severe history of post-op nausea and vomiting or who is intolerant to some of the other medications that we use for the anti-nausea protocol that we already talked about. So Phenergan is our last case scenario. If we're going to use it, we try to use it in pre-op. So by the time they get to recovery, they're not as sleepy as if you dose them in recovery. Intraoperatively, patients get 10 milligrams of Decadron IV for nausea control. Diabetic patients, we limit that to 4 milligrams of Decadron for the anti-nausea properties. The reason we give the 10 milligrams to other people is not only for nausea control, but also for a little swelling and stuff like that from the surgery. Postoperatively, we may repeat the Zofran, and then we may add another dose of Phenergan as needed for people with the post-op nausea and vomiting. We also have Mylicon drops as or even the Gas-X tablets we have, depending on what we've gotten from pharmacy. But we have that as a last case or issue also, especially for occasionally we have people that are just full of, belching a lot. So we'll give them that at that time. For intraoperative and postoperative pain control for the knees, when you come in and check into our pre-op area, everybody is given Celebrex, Lyrica, and 1 gram of IV Tylenol. You're also given Vicaprofen if you are over the age of 70, or 10 milligrams of oxycodone if you're under the age of 70. On occasion, I will give people in the 70 to 75 age group an oxycodone if they're people who are still very active, whether they are playing tennis on a weekly basis or daily basis, or if they're golfing several times a week and are very fit and active between 70 and 75, I will sometimes give oxycodone, but that's on a case-by-case basis. Everyone who's having a niece gets an adductor canal block with 10 mLs or 133 milligrams of Exparel or liposomal bupivacaine. That is mixed with 10 cc's of 0.5% bupivacaine and 10 cc's of normal saline. That will be done ultrasound guided with a little bit of sedation, and fentanyl 100 mics is our sedation 90% of the time. Occasionally, someone may get only Versed, or they may get both fentanyl and Versed, but 90% of them just get fentanyl. Most of the people tolerate it very, very well, and oftentimes we're told that it hurts less than getting their IV. People that are under the age of 70, we will do a sciatic nerve block on, and we have adjusted that. The slide here says 10 or 20 mLs of 0.1% neuropen with Decadron. We have actually decreased that to 10 to 12 cc's of the 1% neuropen with Decadron. And we limit that to age 70 because there is even a little bit of occasional foot drop and muscle weakness with even the 10 mLs of the 0.1% neuropen. Again, if you're 70 to 75 and I've deemed you fit and you got the oxycodone, you're probably also going to get the sciatic nerve block. But that's maybe 5% of the people over the age of 70. 70 is our cutoff most of the time for the sciatic nerve block, and it's due to they're just not as strong as younger people, and we don't want to deal with weakness postoperatively. For intra-op pain control for the knees, intraoperatively, they get fentanyl 100 mics. Not everybody gets fentanyl. We base that on vital signs, blood pressure, heart rate, etc. And usually respiratory rate is a big driver. Probably 90% of our people get the 100 mics of fentanyl, but not everybody. Some people will get none. We just titrate that in as needed. The Toradol, 15 to 30 milligrams, depending on age and creatinine, will be worked in towards the end of the case. And postoperatively, if people get both blocks, we rarely give anything postoperatively more than 50 mics of fentanyl. You see the other things we have down here that we will give. Typically, someone who's ready for discharge, by then it'll be 6 hours and they'll get their second gram of IV Tylenol, and we'll give them a Vicaprofen for the road about 50% of the time. We try to get the second gram of Tylenol in everybody, but we don't always get it in people. Sometimes people meet discharge criteria before their time limit for the Tylenol was up, and then they just don't get it. The Valium, 5 milligrams for muscle spasm. Young men, basically 55 and under, tend to have a lot of muscle spasms in the thigh after knee replacement. Almost all of them get the 5 milligrams of Valium. Beyond that, it's used maybe 10 or 15% of the time on people that are having a lot of cramping in their legs. So it's not part of my pre-med. If you're having hip surgery, you do get a muscle relaxant as part of your pre-med, but for the knees, it's not part of the pre-med. But I would say when you factor in the young people, 20 to 25% of the patients end up getting Valium for a knee surgery in recovery room. So changes along the way. The blocks, really the only change we've made from inception on the blocks is decreasing the concentration and amount that we use on our sciatic nerve blocks. When we first started, we were doing 20 cc's of 0.2% neuropen. And over the years, we've knocked that all the way down to 10 to 12 cc's of 0.1% neuropen. That is more than adequate for post-op pain control. And we have very, very minimal muscle weakness or foot drop with that concentration and that volume. Opioids have really remained unchanged. We've had the OxyContin and Vicaprofen pre-med from the start. We do less opioids intra-op than when we first started. Typically, people got about 200 mics of fentanyl in the first year we were open, roughly. We have weaned that way down to where 10 or 15% of our people get no opioids intra-op or post-op. All of the pre-meds or blocks have taken care of that for us. Urinary retention is a problem for the population, you would think. Males over the age of 60 or 65 that have prostate issues. One thing that we went away from is IV Robaxin. We found that caused some urinary retention. And anybody who's got a history of any type of urinary or prostate symptoms, we give them Flomax. And then we occasionally have women who tell us they have trouble urinating after surgery. They get Flomax also. Since we've implemented a fairly liberal use of the Flomax, we have had very few people who we've had to straight gaff before they got sent home due to just feeling distended. Muscle cramps, again, if you get rid of the young male patients under the age of 55, it's maybe 5% to 10% of the people have muscle cramps that are bad enough that we end up treating them with Valium. If you factor in the males under the age of 55, we get up to maybe 20% of our total population that ends up with the Valium. Joint camp, we found, really, really makes the experience much better for the patient and our staff. The patient knows what to expect. It limits questions. When things happen, they know why it's happening. It makes them feel more comfortable with the process. Joint camp is mandatory. Probably 95% of our people do joint camp. There's a few people that slip through, and you can usually tell who they are in pre-op. But the joint camp really just makes the experience smoother. I get on the joint camp Zoom when I'm here. So we do joint camp Zoom twice a week. If I'm in the building, I get on and do a 5-minute spiel about what to expect from the anesthetics. I talk about hips and knees at the same time because we don't separate them out for joint camp. We just do joint camp for everybody. I hope this helps give you some ideas on how to modulate your anesthetic protocol and hopefully and get a little better outcome or results from what you currently are getting if you're having issues. Again, my name is Tim Osborn, board certified anesthesiologist. Happy to answer any questions. You can email me here at the center and I'll be happy to answer them for you if need be. And enjoy your conference.